Hello, everyone. Hope you're safe and healthy. On May 12th, Shah Lab hosted a webinar featuring speakers from the World Bank, Indiana State Department of Health, Intellectual Ventures, and Plan International. The goal of the webinar was to discuss the innovation gaps and needs as they see in their daily work towards managing the response of COVID-19 crisis, and also the challenges that they anticipate for the future post-pandemic world. We wanted to understand how innovation can accommodate, adapt, and help manage those challenges. The host of the webinar, Shah Family Global Innovation Lab, is part of global engineering programs and partnerships in the College of Engineering. And like many at Purdue University, we too derive our inspiration from our land grant mission of advancing research and development focused on our world's most pressing challenges. The core of Shah Lab's work is to facilitate translation of cutting edge research, technology, and innovation into relevant, scalable solutions for social impact. And we do this by facilitating collaborations between like minded researchers, practitioners, and implementers to combine their strengths and create evidence based solutions for addressing global challenges. As of this year, to fulfill our mission, we have partnered with more than 40 external collaborators that include universities, donors, and nonprofit organizations to co create solutions that cater to the bottleneck challenges in more than 12 countries. This work is done through the pool of our affiliated faculty and researchers from across campus, from engineering, agriculture, science, polytechnic, human sciences, pharmacy, and in partnership with our Research Foundation and Discovery Park. With their collective support, we are trying to tackle challenges in critical areas of water and sanitation, food security, global health, clean energy, environment and infrastructure, education, and humanitarian response. We are happy to share the full recording of the webinar with you. Unfortunately, due to some technical issues, we couldn't record the first few minutes of our first speaker, Dr. Lindsay Weaver's talk. Lindsay is the Chief Medical Officer with the Indiana State Department of Health. She's also an assistant professor of clinical emergency medicine at Indiana University School of Medicine and practices emergency medicine at Methodist Hospital in Indianapolis. She's also the lead from Indiana State Department of Health on IU Fairbanks prevalence study. During the COVID-19 response, Lindsay is charged with overseeing testing in Indiana and has been working with labs like Eli Lilly to establish their testing for the state. She's also in charge of setting up testing collection sites, procuring swabs, working with hospital on prioritization of testing, and also developing a plan for moving forward. We wanted to learn from Lindsay the various pitfalls, bottleneck, and barriers to COVID-19 response that she is seeing in her work, and how, in her opinion, could we be better prepared for the future. We also wanted to get her opinion on the top challenges that she would like to see engineers and scientists work with public health officials to address and resolve. We now proceed with a full recording of the webinar.
That were critically ill that we'd have to take care of in Indiana. And so we set to, lots of different groups to help us with that modeling. And again, they were working off very minimal information. So that was pretty difficult, right? So they were looking at what happened in China and could they say that was going to happen here based on our, how many people that we had over 60, how many people we had over 80, and then also here in Indiana we have higher risk populations, more people with diabetes, more people with high blood pressure, more smokers, definitely more obesity than other states. So our projections were going to look different, we felt, than some other places. So we had, number one was modeling. How can we best prepare? What should we expect for? Number two, we realized we're going to need way more ventilators to take care of these people, knowing that they do require the mechanical ventilation if they get the severe lung disease. And we had a fixed number here in Indiana. So very quickly, we identified, okay, we have ventilators in operating rooms. How do we best use those as critical care ventilators? And so when we were talking about that, we recognized that our critical care physicians, our ED physicians, me included, we know how to work our normal critical care ventilators, but we do not know how to operate these anesthesia ventilators. So we had all these people who we knew that needed ventilators. We had these additional ventilators, but we didn't have the people to help us train. So we identified that we needed to know the modeling, how many sick people were we going to have. We identified that we needed more ventilators, and then we identified we needed to retrain our people. So we also reutilized all of our physicians and nurses and trained them to be in different roles so that they would be better prepared to take care of those severe people. So for example, many hospitals across the state trained their anesthesiologists, and they basically came up with intubation teams. So the anesthesiologists moved about the hospital to intubate patients, and then also to help with those anesthesia vents when we needed to use those. And thankfully, we didn't end up needing to use very many in Indiana, but we were prepared to do so. Additionally, we trained the OR nurses how to be critical care nurses. We trained the family medicine doctors to come in and help us be hospitalists in the hospital. And so I think if you would talk to any hospital system or hospital CEO, those are the two things they're most worried about. They said the first thing we're going to run out of is people and ventilators. And you know, you'll hear a lot in the news, and we talk about it, about the ICU beds. And if you talk to any doctor, any hospital administrator, they'll be like, I can put an ICU bed in the cafeteria. It doesn't matter really about the space. It's, do I have somebody that can take care of that person? And do I have the equipment and machines that they need to best take care of them? So we very quickly, again, it required a lot of technology and coordination. We realized we had no insight at all across the state of Indiana of how many ventilators we had, how many were that people either buying or turning into anesthesia ventilators, how many, how worried were they about physicians. And so we had every hospital in the entire state start to import their data into a system, so that in real time we could see how they were doing with their ventilators, with their ICU beds, with their providers, and also how they were doing with their personal protective equipment. So again, that was kind of the next thing that we realized we were going to become very short in, and people immediately became very creative in how they could best use PPE. So we knew that the recommendations typically is that I only wear my N95 mask for one patient, and then I threw it away. So I mean, we look back and we're like, if we only would have known, we would have been doing things way differently, 6 months ago, a year ago. We would have had produced more than what we had. We do believe that reusing N95s, while not it's not ideal, is actually okay if they don't become soiled. So I think a lot of changes in our practice. Additionally, people started working on how could we potentially clean these. So because they're made out of a material, polypropylene, there's kind of like lots of nooks and crannies. So it's not just easy as, spraying and wiping it down. You can't do that. They also looked and said, hey, could we use UV light? We knew that UV light does treat other coronaviruses, and could we potentially use UV light for it? But again, how do you get that UV light down into all the little tiny, nooks and crannies of these masks? And we just recently received at the state of Indiana, it's called a Battelle machine, and actually uses hydrogen peroxide, and I think goes through 20 cycles, and we can actually reuse the masks 20 times after they clean. So very quickly, a lot of new, really, genius, great systems of how do we best use what we have in order to maximize, honestly, everything that we have. We almost practice completely different in medicine. So I will tell you, we had a whole section of my emergency department that was just curtains, right? A big open space with curtains. And within 2 weeks, they turned it into 5 negative pressure air rooms. So the walls went up, they figured out how they're going to circulate the air, put all the equipment in, and now we're utilizing those, as we probably should have been utilizing that space for quite some time. So I think the next scarce resource that we figured out we had at the State Department of Health was the ability to test. So I always talk to people that there's all these different components to testing. So one, you actually have to have, the swab and then the viral transport media to do the test. And then the test has to go to a lab that has the right equipment that can do the test. In order to run that test, you have to have the right reagent. So, I mean, within weeks, we were out across the country with all of those things. So people started to do different experiments. Could we use different swabs than what we were typically using? Do we not need to use viral transport media? Could we use saline? And just really trying to figure out, again, how do we utilize what we have. I talked to several companies that were wanting to 3D print the lab or the swabs for us. Unfortunately, we just couldn't get the tips right in order to really be able to collect the mucus. But now that we do have some that are on the market that are some 3D printed labs. Additionally, I know people that 3D printed the N95 masks and started putting them into production, and or something like an N95 mask, but a respirator that you can actually wipe down and reuse. And then with the reagents, of course, more companies came on board. We're able to use more machines. And so we have all these labs across the state that had no ability to test. And we immediately realized we needed a coordination across our state and how we could direct people who wanted to do the testing to the right lab or to labs that had testing availability. So probably 6 weeks ago, our turnaround time for lab testing, when we would send it to these outside labs, were anywhere from 7 to 13 days, which is way too long because we really do change our practice and what we do for some of these patients when we find out they are positive. Eli Lilly came on board very early and was willing to do the testing on behalf of the state. So we actually, have people manually extracting the RNA in our lab, and Lilly was able to use a machine that did that automatically, or without the use of individual people to do all that manual extraction. So they were able to increase their capacity significantly for the state really early. And honestly, I don't know what we would have done as a state in those early weeks without all the work that they did and they put in. And additionally, they've helped run experiments for us on, if you do that nasopharyngeal swab, the swab that goes way back almost to your brain, it seems like, versus an anterior swab, is it as accurate? So I want to say that's probably one of our biggest pitfalls we have now and will have moving forward, is that the tests that we have to see if you actively are infected with the virus that causes COVID-19 is not a good test. It is only about 70% sensitive on somebody who is symptomatic. It is only 40% sensitive on someone the day before they have symptoms. And we think it's around 20% sensitive for somebody who has no symptoms and may never develop symptoms, but could potentially be spreading the virus. People always kind of ask questions about that. The reason why it is so, it's not sensitive, it's not actually the test. So if the virus is on the swab and gets into the media from the swab, the actual test is 98% accurate, the chemical test, at picking up and recognizing the virus. The problem is when you do a swab of someone's nose or their nasopharyngeal area, you don't actually know how much mucus did you pick up, right? Did you actually grab the virus? It's not like a blood test where you know if you have blood, right? Clearly you see the blood in the tube, you know you have blood, so that you can send it to be tested. So with that nasopharyngeal swab, that's not the case. So it's not really that the test is bad, it's that the way that we're doing the collection is bad. And this has been true with all other tests that are like that, strep, the flu test, anything that you've gotten a swab for. It's less sensitive because it's just an imperfect technique. I mean, ideally, we would have a swab that turned colors to let you know, hey, there's mucus on this, or some kind of pre-test to say, hey, you got a good sample before we ever had to go down the process of figuring out. Now people are starting to work on a saliva test. So again, right? If you have saliva, you can actually see it go down into the tube. And so they are currently working on that. And honestly, that would be wonderful. One, because you can have the person do it themselves. So I wouldn't have to wear my mask to do the collection, which what we do now when we take that nasopharyngeal swab, you actually have to wear a mask to take the swab. Instead, we would just hand someone a tube. We could walk out of the room and save the use of that mask. Also, you can do a saliva test at home. You can do it in the family medicine clinic. You can do it in a pediatrician's office, as opposed to right now where most testing is happening in hospitals or in drive-through settings, only because the risk of, if you do that swab and someone were to sneeze or cough, it does put the person who is collecting the swab at risk. And so that's why they're doing it more kind of outside or in hospital settings where we have that, constant air exchange to remove it from the air. So that's something that we're dealing with right now. There's still a reagent shortage. And so we're working with Lilly and all the labs across the state to say, where do we prioritize doing testing so that we can increase our capacity? We have pretty good capacity now, but we want to be prepared if we were to have, a peak in the fall or later in the summer. But how do we really prioritize the testing? And then how do we direct all the different sites across Indiana to, okay, send it to, for example, Purdue Lab today because they have capacity so we can get that quick turnaround time. But tomorrow, maybe Purdue Lab has too many tests, so we need to direct it to another location. So we're looking at how do we use technology really to help direct us, and also, again, to give us insight. So, for example, with the prevalence study, we found a really good correlation with the loss of taste and smell. For patients who ended up testing positive for COVID-19, or if they reported they'd had a loss of taste or smell in the past, they ended up testing positive for the antibody. So that's a super weird symptom and seems to be very specific to this disease. So especially if you have fever plus those, it's really high chance that we're going to end up having you test positive. So how do we use information like that to let me know at the State Department of Health, maybe days before that there's an outbreak in a certain city? So for example, if we have good oversight over all of Indiana and we say, okay, this small town typically only tests about 50 people in their drive-throughs a day, but all of a sudden 250 people show up and they have all of these worrisome symptoms, but it takes us about 2 days to get those tests back. I would know 2 days ahead of time, hey, something's going on in that small town. We need to reach out. Is this a plant? Is this a school? Is it a workplace? Is there potentially an outbreak there? So we would be able to be a lot more reactive if we had that insight and actual ability to see what people's symptoms were and see the number of tests being done at the site way before we ever actually got the results back. Well, I say way before, but 2 days could be a really big deal when it comes to an outbreak, especially knowing that we have so many people who totally have no symptoms but are walking around spreading into other people. So these are the kind of things that we're thinking about as we look forward to opening up more businesses and also, going back to school, hopefully in the fall. How do we be prepared for these situations? How do we stay on top of it? How are we communicating? And then what do we do when we actually see an outbreak? So again, like I said in the beginning, the research is constantly updating and changing, and the CDC recommendations are constantly updating and changing as the new research comes out. For several weeks, the recommendation is that you isolate at home for 7 days, but then we found out that they were still culturing active virus about 9 days out. And so they changed the recommendations to isolating for 10 days. Of course, we're working on our contact tracing and how do we best use technology to do that by texting people. And I'm sure you've heard about, using your phone data and your location data to say, okay, you were in close contact with this person for within 6 feet for greater than 15 minutes.
Yeah.
Does that person get pinged? We're not doing that here in Indiana, but people are definitely looking at how do we best use that kind of information to do the contact tracing in the future. So those are all the things that we are talking about and looking forward to and trying to come up with best solutions for.
Thank you so much, Dr. We appreciate it. We'll move on to our next speaker now, Dr. Michael Woodcock. Michael is a lead social scientist with World Bank's Development Research Group and is also a part-time lecturer with public policy at Harvard University's Kennedy School of Government. Now, besides his multiple ongoing research that you can read about on our website, Michael is currently co-leading the World Bank's next Poverty and Shared Prosperity report that is scheduled for release in October this year. The report provides an update on the progress being made towards reducing the global level of extreme poverty by 3% by 2030. This is an interesting topic to explore in today's environment, as the policy implementation issues are amplified across the world as countries struggle in their own ways to reconcile the tension between saving lives and saving livelihoods. In US alone, unemployment has risen to 14.7%, the highest we have ever seen since 1948. And it may actually hit 30% in the second quarter, as Federal Reserve Bank President predicts. Now, that would mean 15.4% of Americans will fall into poverty this year. Michael, this is grim. And I'm especially eager to understand what impact do you think COVID-19 will have on global poverty, and what types of social technologies and social innovations will be needed to address issues of poverty and future and current health crisis beyond the more familiar medical interventions like vaccines and infrastructures like facilities and transport. And also, what are some of the key challenges you would like to see engineers and social scientists work together to resolve in the face of today's crisis, and perhaps be better prepared for the future such crisis? Michael.
Thanks, Pallavi, and thanks to all of you for joining in. And before I say anything else, let me just congratulate the previous speaker and all those who are working on the front lines. My work is very safe compared to what you guys are doing, and I'm very conscious of that, but we all have to do what we have to do. And so I'm doing what I can, but I just want to acknowledge that it's a very different experience to risk your own life to do your job as opposed to just thinking harder about it. So I hope those on the front lines do indeed know that they are being actively supported by and encouraged by those that sit home and watch TV, because that's what the science says they should do. I'm just going to answer Pallavi's questions briefly, just because there's other people you want to hear from, and because there's each of them in its fullest sense would require a much more detailed explanation. So I just want to give you a brief overview of how things currently stand, at least with the impacts that we think COVID-19 is going to have on global poverty, and then we'll just talk a little bit about some of the non-technical, non-engineering type solutions that I think are pretty central to thinking about all of this stuff. Which is, of course, not to say that medical and engineering and all the technical professions aren't needed. Of course they are. There's so much we need to learn, and as we heard from the previous speaker, there's so much real-time learning going on, which is so important. And I'll have more to say about sort of the systems I think that we need to encourage that kind of approach more frequently and at scale. But I'll just start off with sort of the numbers, as it were. There are different ways, of course, to try and get an empirical handle on this big question. Various different organizations and people take reasonably different approaches to how they think about that. With my colleagues at the World Bank, we're writing this report at the moment on which updates the world on progress or lack thereof towards the attainment of our twin goals, which are the reduction of extreme poverty to less than 3% across the world by 2030, and the promotion of inclusive growth, which is probably the main mechanism for ensuring that, or at least maximizing the likelihood that that particular goal will be achieved. There are different ways to do this, but the World Bank is the curator of around 160, 170 different surveys from different countries around the world, all of which are provided, we think, the most granular and detailed understanding of the dynamics that are shaping poverty, especially over time, and for different groups and the different levels of poverty within particular countries. So it falls to many of my brave colleagues to try and calculate all this stuff. Our report itself regards as current data, data that was collected in about 2018, because that's how long it takes for it to go from being collected in the field to then being properly cleaned and verified and checked, and then and all the different pricing calculations that then have to be done to ensure that the metrics that we use to assess poverty in country A are similar enough to those used in country B, etc. So it's a huge, big behind the scenes exercise to making sure that the data that we collect does the work that we want it to do. All of which is to say that anyone trying to make an estimate of the effect of a major shock like COVID-19 happening in 2020 is largely going to have to do this as an exercise in extrapolation, in trying to look at what we think the past trends are and what shocks of this magnitude are likely to do to economic growth around the world, and by extension then what effect that slowdown in growth will have on the rates of poverty reduction. there are different ways or rather different levels at which we then measure poverty. The most extreme poverty is measured at those living on up to roughly $2 a day, $1.90 to be precise, for reasons I won't go into, but roughly $2 a day, which is just extraordinarily low by any normative ethical standard. You are just living, you're barely able to just keep your body functioning in the poorest countries on that sort of level, let alone work and earn a living. So we have poverty at the most extreme level, 190. Then we have others at 320 and 350. So we have these three different lines that are able to measure, that gauge the extent to which poverty is prevalent, and then over time the extent to which that then is being reduced. Since 1998, we've had every single year around the world, at least in aggregate, a reduction in global poverty, which is great. That's an average. So of course, some countries have got worse, perhaps as a result of war. Other countries have done spectacularly well. Some countries haven't always done well every single year, etc., etc. But on average, since the last 22 years, poverty has gone down, and it's been probably the longest and sustained and most effective reduction of poverty in human history. So we need to recognize that as an extraordinary accomplishment, despite all of the awful things that greet us on the headlines in newspapers every day. But at least at this moment, using that household survey data, we can show roughly that about an extra 40 to 60 million people at this extreme poverty level will be pushed back into poverty as a result of COVID-19. If you raise that line to 320 or even up to 550, then you're starting to look at an additional potentially over 100 million extra people that will go into poverty. So on aggregate, we're thinking roughly 160, 170 million people will be much poorer in a very real and consequential sense over the next year as the full effects of COVID-19 wash through their systems, as it were. You can obviously also appreciate that the effects will be heaviest in those countries that have large percentages of their populations already living close to that poverty line. But this is where we can get into semantics or deep methodological issues. But of course, in some sense, the poverty line is a construction. It exists to help us just make claims like I just made about how many people are truly living in extreme levels of poverty. But it's not like your world is materially different, even when you go from $1.80 a day to $2.50 a day. There's a wonderful project online that you can look at just what different households around the world look like, even from the very poor living on $1 a day all up to $5 or $6 a day. And to the naked eye, it's very, very difficult to discern any real differences materially between those. But for statistical purposes, for accounting purposes, for accountability purposes, we impose these kinds of restrictions on ourselves. So if Shelby can share the first slide that I have with you, that'll give you a sense of then over time what that trend of extreme poverty at least has looked like. And that graph shows you, if you're looking at it now, that the global poverty has declined by roughly 0.5 percentage point every year over the last decade or so, or even further back to 1998 if we push it back that far. The World Bank's goal, or the world's goal through the Sustainable Development Goals, was to reduce that level of extreme poverty to 3% by 2030. And as you can tell just by doing a basic extrapolation of those trends, the world is not on path to meet that goal, as commendable as the progress has been. Two previous poverty and shared prosperity reports have made clear that we just need to keep trying harder. Essentially, the world needs to keep trying harder. Those numbers are going down, which is great, but they're not going down fast enough, and they are probably going to be not asymptotic, but it just gets harder and harder to reduce poverty the lower and lower it gets, because the people that are the very, very poorest are the most isolated, the most discriminated against, and just the hardest to measure in the first place. So either way, at best, we were looking at the world was looking at a situation in which that rate of extreme poverty would have got to roughly about 3% by the middle of the next decade, by middle of the 2030s, I mean, by 2036, 37. if we take these latest estimates from my colleagues at the bank at face value, that would suggest that unfortunately, where the effect of of COVID-19 is going to be that it pushes back that goal by at least 3 years. So probably now 2040 until that happens. But of course, there's a whole bunch of ceteris paribus assumptions built into all of that, and who knows what other effects might happen as a result of not just of this particular pandemic, but perhaps other even more deadly ones still to come that we don't know about, or the ones we kind of do already know about around climate change, which are imminent and are going to probably unfold sooner rather than later. So, but it's just going to be a very, very hard task to achieve this goal, even in the best of circumstances, and COVID has just made it much more difficult than it already was. My particular interest spans the full range of medical and engineering responses, but my particular focus is on the social aspects of all of this, because as we've seen, certainly in this country and elsewhere around the world, there's just enormous variation in the way that societies have chosen to or found themselves responding to these imperatives around social distancing and taking seriously the advice of medical experts. And that's hard enough, in wealthy countries. It's harder again, and especially ethically difficult in countries where people live in slums, where people literally can't uphold social distancing norms, or who are illiterate and really just don't have any understanding of how what a virus is, how it spreads, what are the both logical and scientific ways in which one should respond to all of these. So I think those are the things that I'm particularly interested in. My particular training is a historical comparative sociologist, so I'm very interested in how previous eras of history have addressed these responses. So, that approach actually helps me to be much more optimistic in this situation. Sometimes I get very pessimistic, but I think when you look historically at the effects of the most crazy examples, like the Black Death of the 1300s and the Spanish flu of the early 20th century, all of those were just vastly more consequential in terms of their impacts, but because we didn't have the kind of response mechanisms that we just heard about in the previous presenter, and what we see happening all around us. And I found this really nice response from Ada Palmer, who's a historian at the University of Chicago, who also is a historian and studies these things in a longer term perspective. I'm just going to read you a little passage from her, because I think as much as we need to be self-critical, as much as we need to hold accountable people whose jobs it is to do this, I think we also just need to be truly recognizing that the way in which the world is responding to this right now, for all of its problems, is actually quite extraordinary. So I'll read what she wrote on a blog post a week or so ago. I'm in fact awed at how great a job humanity is doing now. The first pandemic where we've understood hygiene, hand washing, where we've had actions we could actually take. In 19, they didn't even discuss delaying a national election because there was nothing they could have done to make it safer, even if they didn't want to delay it. They didn't know enough about how the disease spreads, disinfect stuff or anything. I know we're focused a lot on the mistakes that are being made, and they're huge. But since my head is usually in the pre-modern world, I sit in awe at how much we're doing, how sure we are that we can handle it together as a species, how empowered we are, and how much we're reaching out and being warm and helpful to each other. Some governments are botching things, as are some individuals, but the collective is doing one of the most impressive things any species has ever done in the history of this planet. We just need to keep ourselves being reminded of that. I want to open with that sort of as much as I now go to sort of try and look at some of the problems we do in fact face, but I think taking this bigger perspective, either a global perspective or a historical perspective, just helps us to realize that as much as the pain is being experienced in a very graphic and real and deeply painful way by millions of people, the world is actually much better positioned to respond to this than it's ever been, and we're doing that. I just get Shelby to put the next slide up, because this is sort of what happens when we start to move from the recognition of these big problems into trying to apply social science and apply our analysis of these prevailing response mechanisms, and try to help then identify where entry points for doing a better job might be. The slide that I hope you're looking at was produced, interestingly enough, just back in October of last year, which rated all the countries on the world on how well prepared they were to handle the pandemic. And that was a very serious exercise, that dozens of people that were all brought together to try and make sure that everything was thought about, and that the kind of numbers and indices that were put together to try and come up with these overall numbers was all done doing what counts as the cutting edge of how you do index construction, and how you try and then mobilize people around the kinds of information that emerge from those kind of things. But as you can see from that chart, the US and the UK were deemed to be the best prepared countries in the world for this particular response, even though those countries are now, as we look at the awful data from Johns Hopkins University on a daily basis, those countries are suffering the worst numbers of deaths of any country in the world. And I say that not to second guess people that did the index construction at all, because I think those kinds of exercises have their place. They're how we do show how big the gap is between what we need and what we actually have. But I think it shows very much that there's so much that affects response mechanisms that our meta indices just can't capture. So in the statistics, we would say there's just, with all these problems just riddled with unobserved variables. They're things that matter, but they just don't. They're not rendered legible by the scientific instruments or by the surveys that we might otherwise conduct to help us get a handle on these things. So if you took this particular index at face value, you would note that New Zealand, for example, which has had literally 25 deaths across the whole country, gets rated lower than Brazil, which is the country leading Latin America now in terms of the number of deaths. So there must be something going on in New Zealand that was just not able to be captured in the way that indexes were constructed that would predict the kinds of outcomes that we have. And maybe that's just good luck. Maybe just, New Zealand's an island in the bottom of the South Pacific. Maybe they just had a really low initial incidence of this particular virus, and so shutting it down just wasn't the same kind of problem that it was in New York City, for example. But either way, as you've just seen from a lot of analyses in the popular press in recent months, there's even the variation between Denmark and Sweden, for example, in terms of how they've got all that. All of their public health experts are reading the same scientific journals that everyone else is. They've more or less got state-of-the-art facilities, state-of-the-art resourcing levels to be able to address all of these, but have chosen very different paths. And those paths are social paths. They're born of people's tolerance for accepting death, their willingness to trust authorities to either do or not do things that they would agree with, the legitimacy and trust that they have in those public institutions to take decisions that will ultimately be the best in the short run and in the long run. And Sweden, for example, seems to be very committed to a long run view of this, and that they are willing to take the pain in the short run in order to be able to keep their economy alive in ways that their Danish and their Norwegian friends just aren't. So my point is that there's just a huge social underpinnings to how different, right down to the community levels, that shape how this kind of information that we receive from scientists and how the kind of technologies that medical engineers come up with to respond to it plays out. And I want to suggest that that's a really crucial and underappreciated factor shaping how and where and to the extent to which we are able to make effective responses to that. If you go to a country like India, for example, my friend at Brown University has a nice analysis showing or explaining why it is that Kerala, all the states of India, has responded so much more effectively than other states in India to this pandemic. And again, showing that a lot of it has to do with not just their resourcing levels that are available, or having access to better technology. Those really don't seem to be the key factors. The key factors are the willingness of people to be able to respond quickly, to respond effectively from the supply side, as it were, but from society side, from the demand side. People's willingness to be really willing and able to accept these short-run hardships and regard that, see this particular problem as a collective problem that requires a collective solution. And those are very different kinds of mental models. They're very different kinds of societies, really, that have those kinds of normative assumptions about how and the extent to which groups should be responding to all of these things together. So my big hope out of all of this is that the kind of response to all of this will be what we should do from history more generally all the time, which is to try and just help our organizations to learn from past experience and to learn even from our contemporary analyses, like the index that I just mentioned before. All of these tell us things. They all help to identify where weaknesses are. And good leadership in this space is about trying to mobilize the resourcing and the community support that we need to get those resources and then to get the right responses and then to respond to those right responses. And there's so many different points in that implementation chain where things can break down. But that's what I think we should be doing, much more of those kind of things. And that should be much more part of our public conversation around these things.
Right. Thank you, Michael.
I'll stop there. I have other things to say, but maybe we'll have a second round. Thank you.
You know, I really liked the presentation, and especially the aspect of trust of citizenry over the government, which forms the basis of sort of collective civic responsibility. And I would be very interested to see a global health security sort of index for developing countries, including India. Thank you again.
Yep.
And our next speaker is Maurizio Vecchione. Maurizio is the Executive Vice President for Global Good and Research at Intellectual Ventures. In this role, he oversees IV's collaboration with Bill Gates to invent and deploy technology specifically focused on improving lives in developing countries. Maurizio also sits on the state COVID-19 task forces for Washington, California, New York, and New Jersey. He's providing both states and federal government with modeling support using the resources of the Institute of Disease Modeling, which is a leading predictive disease modeler group in world of epidemiology. Maurizio is also on the board of UCLA Medical Center and University of Washington Medicine, which gives him a direct clinical experience. Maurizio, as I understand, that the Institute of Disease Modeler is quite unique in its statistical approach to model the interaction between the social behavior and the disease spread, and that you're also working with the WHO and CDC in almost 130 low-income countries in modeling the impact of social distancing and translating it into strategies for reopening. So clearly, Maurizio, we live in a globalized world, and where the threat of reoccurrence of pandemic is not only possible, but in some ways almost certain. What, in your opinion, are the critical aspects of a disruptive new healthcare technology that we are going to need in order to be better prepared for such a scenario in future? Now, these technologies, as I understand, could be in form of software, perhaps using machine learning or AI or data science, or even devices that are equally applicable both in lower and middle income countries, but also here in the rich world.
Thank you, Pallavi. So many of you in the Purdue community have heard me talk about these topics before. You know, one thing that strikes me as we go through the current pandemic is perhaps the attitude that we're hearing often in the press, that this is a once in a lifetime, once a century emergency, that this is something that could not have been foreseen. When the reality is there's vast predictive analysis of the likelihood of a pandemic of exactly this type that dates back now many, many years. All you have to do is go look at the TED Talk that Bill Gates gave 5 years ago, where it's almost eerily predictive. And those of us that look at things from a modeling perspective had a pretty good sense of how unprepared the world was, despite the relatively bullish outlook that a lot of our public health and other healthcare system providers were providing. The simple fact, when you really look at it, is the frequency of epidemics and pandemic is increasing, is accelerating. If you just look at the last few years, while we haven't had a pandemic, we've had many epidemics. Just think of Ebola, just think of SARS. And there is no question that there are factors of work on a sort of macro basis, whether it'll be on the social side, as Michael suggested, or whether they'll be at the pressures from the environment, such as climate change, that appear to be accelerating our risk profile for this type of event. So as we start thinking about the post-coronavirus world, we have to really, and as people talk about, let's return to normal, we have to really start asking the question, what is normal? And, you know, I have a picture behind me of Santa Monica Beach in California. And that is an urban beach that is attached to a community of almost 20 million people. Okay, just to put it in perspective, you know, the county that hosts this beach is larger than most states in the country. That beach is empty. And it's not empty because the county has prevented people from going there. It is because people are afraid. There's a new normal that is taking place in consumer trends, you know, in other trends that parallel, to go back to Michael's historical parallel some of the long-lasting and enduring changes that other disasters have established. Think of 9/11 and the security changes. Think of even enduring changes that historians have attributed to the Spanish flu in terms of what happened in the early 20th century post the flu. And so what I am trying to communicate is that the needs in the healthcare sector, the needs in the social sectors are in many ways going to be fundamentally changing because the virus is not a one-time event. Even if you don't assume the rest of the pandemic world, the forecasting really suggests that this is going to be something that is with us for a sustained amount of time. It doesn't just go away. To illustrate that, I'm going to share with you one of just 2 slides that are, in this particular case, is part of a modeling study. And it's part of a modeling study that our Institute of Disease Modeling has done, specifically looking at the Seattle area and King County. And what this is a very different curve than the one that you may be used to seeing from the popular press and everything else. What this is tracking is what is called the R0 factor. So this is actually looking at how infective or how much is spreading, how much of the disease is spreading. And that dotted line kind of crossing the bottom middle is 1, which means anytime the spread is above, or the R0 factor is above the line of 1, the disease is growing. And anytime it's below, the disease is shrinking. Now, look what's interesting. As for Seattle, which, by the way, was one of the first places in the country to not only see the disease, it was the first documented case in the U.S., but it has also been one of the first to apply social distancing. You can see that the impact of social distancing has really driven down that R0 factor to just about 1 or just below 1. But then the interesting question is, as you start looking at the relaxation of social distancing, as you start looking at the return to normal that we talked about a minute ago, that sort of yellow shaded area start giving you a bit of a sense of what it's likely to be happening, where essentially the R0 factor will oscillate, which means the disease will oscillate between continuous spreading. And the oscillation comes from the fact that we're anticipating our public health to be intervening as new reservoirs of the disease or new outbreaks are identified. So assuming good testing, assuming good contact tracing, assuming all of these sort of best practices in public health, you're still going to have a disease that is teetering on returning to exponential growth. And that is likely to go on forever, at least until we can reach the kind of immunity that only a vaccine and a highly prevalent use of the vaccine will come into play. And of course, that scenario of perfect testing and perfect contact tracing is far from being real today. So this is a long-winded way of telling you that the return to normal is likely to be a change in behavior, in social behavior, in economic behavior, in clinical behavior, that fundamentally changes the way we interact with the healthcare system and the way we think about, from a social component, the way we are likely to think about social interaction. And as you really think about the implication, that has a ripple effect. The way we approach taking a flight, the way we approach going on vacation, the way we approach going to a restaurant, are potentially going to be enduring changes. Not to say we won't go to a restaurant or we won't go on a flight, but to say that we're going to need to rely on a whole new set of trust factors, many of which are technological in nature, to try to feel safe and to try to thrive once again. So this is the negative side of this message. The positive side of this message is that technological innovation has historically always helped us overcome these challenges. And so I do think that we are in a unique moment in history when it comes to science and engineering, when it comes to some of the revolutions that science and engineering was essentially bringing us, whether it be on the genomic side, whether it'll be on the in vitro diagnostic side, whether it'll be on the social science even. The fact that we can even look at models of this type that can attempt to understand the interaction between social behavior and a clinical factor. To me, represent a huge call to action to the engineering community. But it needs to be a call to action that doesn't just worry about the technology, but worries about how the technology is going to be used in the social context of the new reality that we're facing. And in that sense, I really like Michael's sort of comment that we have to think about how people are going to use the technologies, how it's going to help them thrive, and we have to look at all of those components. And of course, those of you that are active in global health know that when we've looked at the realities of technology impacting the global health community, to impacting the poorest countries in the world, the populations that are teetering on those $2 a day, we have known for a long time that it's not just a matter of parachuting in some new technology, but that you have to follow what I call the 3 A's in order to essentially merge the social elements, the human-centered design elements with the new technology. And so, I would challenge today our engineering and scientific community to essentially say, we are all now in global health. The pandemic has caused us to look at every healthcare system, including those that were ranking really high on Michael's statistics, as now having the same realities on the ground and the same realities in interfacing with the social fabric of society that existed and that we all recognized in the poorest parts of the world. To some extent, we are now one global village and we're sharing very many of the same issues. I would even go as far as saying that healthcare systems that have been dealing with infectious disease on a broad basis in the developing world are actually better equipped and seem to be responding better than some of the very high tech and high touch healthcare that had developed in the first world. So to engineers, make sure that you focus on these 3 A's, and 1A is affordability. The other 2 A's is accessibility. So can the people that you intend to be the user and the targets for your products and technologies, can they actually use it? And finally, the 3rd A is appropriateness. Does it fit in the continuum of care? Does it fit in the continuum the economy in ways that it actually moves the needle, or is it just another technology in search of problems? So those are three principles that I would call to action to our community. I will show you one more slide just to sort of wrap my remarks. And we've heard a lot, including from Dr. Lindsay, about the need for testing. And of course, a lot of what she told you about deals with the current emergency. So that deals with how is the public health and the clinical sector responding to essentially a peak in this pandemic. But the reality is when you start translating the emergency into sustained need for things like testing and surveillance, let's just think about large employers that are taking their employee base back to work and may increasingly have both liability and occupational health challenges to make sure that their workplace is safe and to make sure that their workers are safe. What the kind of issues that seem to be esoteric work, the kind of issues surrounding contact tracing, for example, and testing, need to become much more of a systemic and much more of an interdisciplinary approach. And so what you're seeing on the screen, for example, is the ability that technology today could offer of integrating surveillance at the genomics level with cloud computing, with clinical data, with other social markers of disease and determinants of disease, so that you can essentially leverage bioinformatics to not only automate the contact tracing, but to actually turn it into a predictive tool where you can identify the potential rise, exponential rise of new disease outbreaks well before they actually happen. And you can start introducing a risk-based management system. Now, I'm not telling you this is the only technology that is needed, but I'm suggesting to you the type of innovation that I think long-term need to be enduring. And the fact that we're in the middle of a next-gen genomic sequencing revolution that gives us the ability to bring down the cost, as well as the availability and the accessibility of these technologies. But beyond the genomic side and beyond the testing side, the fact that you need to put those devices and those technology in a sort of operating system. To some extent, the testing world is where the computer world was before an operating system emerged. And now you need an operating system that essentially automate and enables people to use these things so that you can solve problems like a return to the workplace. Like you can solve a problem, how do you make sure an aircraft is safe? You can solve some of Lindsay's problems at the public health side, where she would love to know before they happen, where are her risks in terms of communities that they should be concentrating surveillance on. So this is, I'm going to wrap with that, but that would be my call to action to the community of innovators that is listening to us.
Thank you, Maurizio. I really appreciate your point of using the technology in social context and the appropriateness of that. And especially if we look at how some of the developing countries are responding to it, the inherent risk of surveillance, using the technology of surveillance and state sort of expanding their power is real. And it's a very critical point. Thank you. And we now will move to Molly. So Dr. Molly Fitzgerald is the Associate Director of Innovation and Senior Health Technical Lead on a portfolio of programs at Plan USA. She's responsible for supporting the development of novel approaches that tackle complex humanitarian and development challenges, prioritizing needs articulated by young people, especially girls, that impede their ability to learn, lead, decide, and thrive in communities where plan works. Molly is also working across organizations to identify strategies on how to work in a primarily virtual context. Really a challenge that a lot of organizations, and mostly is critical in nonprofit sector today. She is working with her colleagues to identify challenges and potential solutions in light of COVID-19, as Plan works with country partners to address needs of young people in communities they work with around the world. I also want to quickly highlight that Molly and Shah Lab affiliated faculty Jennifer DeBoer are co-creating a development model called Girl Engage in Zimbabwe, which allows girls to become drivers of the change they want to see in their own lives. So, Molly, in our discussion today, I would really appreciate if you can highlight the areas that you're most concerned about, especially from the perspective of inclusion and equity, given that COVID-19 is increasing disparities that are more challenging in places that are disrupted by crisis and conflict. Also, if you can share your thoughts on any unique challenges that you have seen disproportionately impacting adolescent girls, and your perspective on how the development community can ensure that the marginalized voices are not only heard, but are actually included in the design process of these programs.
Thank you so much, Pallavi, and thank you for hosting this and for having us. We've been really immersed in these discussions, and I think having sort of working across sectors and disciplines is really really the key to innovation and to solving some of these really difficult challenges. So I actually want to see if I can share my screen. I have just a few slides that I'm going to speak through. So just bear with me momentarily while I see if this works, hopefully. Is that working?
Yes, we can see your screen.
Okay, fantastic. Well, just sort of, just briefly, and thank you for mentioning the Shah Seed Grant that we're very excited about working on with you, and we appreciate the support from Shah on that activity within Girl Engage. Plan, because it affects sort of what I'm going to talk about in the operating context, just a brief note about Plan. I work for Plan International USA. We're based in DC and Rhode Island in the US. However, we do also work with a number of other offices based in 75, I think, different countries around the world. So, you know, we have been in operation since 1937, but clearly this context is having a massive sort of disruption on our work, and so we've been putting a lot of thought into this. And I was intrigued by, you know, some of the other speakers have mentioned that that this although COVID-19 is a novel virus, the expectation that there would be pandemics and other health crises is not at all a surprise to experts and, you know, researchers and people that have been looking at the effects of climate change. But in addition to that, we're really concerned and kind of steeped in the context that are stemming from other effects of climate change. So the climate extremes are causing food insecurity. There's conflict as well, and this is over, you know, land and different political contexts that are exacerbating inequalities. Humanitarian needs are also rising exponentially. There's a rise of extremism, rapid urbanization, and then, as another panelist also mentioned, the point about the changing economic context, and, you know, the fourth industrial revolution, as it's been called, in terms of really rapid uptake of mobile phone technology and internet, which is not universally available, and particularly to a lot of the populations that we are targeting in Plan. So this slide is actually, interestingly, a slide that I used in another presentation several months ago, before COVID. So you know, these things have been really concerning to us for quite some time, and obviously there's new and additional pressing needs that we're seeing right now. On top of this, it's at a time when there are more young people coming of age than at any other period in history. So if you look at the figures for sub-Saharan Africa or particular regions such as West Africa, where we are working as well, those who are age 0 to 24 will increase by nearly 50% in 2050, which is, if you're focusing on youth, as your primary population within communities, then this is really, it's both kind of daunting and it's a challenge layered on all of these other crises. At the same time, it's a huge opportunity. So we're really looking at it as an opportunity to sort of change and transform the future. If we can, our expectation is that if we can meet the needs of young people and sort of alter their life trajectories in a good way, and work to engage them and have kind of civil participation and address issues of equity and equality, then that can really have a massive impact on the future in a positive way. So that is really our perspective. But then obviously on top of this, we're dealing with the very real concerns of the COVID crisis. And I think everybody else has mentioned, perhaps from with different frames of reference, but even Lindsay, from the US perspective, and the different concerns that the health system here is dealing with, are many of, the details are different, but the health system is differently prepared, and there's certainly different contextual issues and things that are affecting the populations, but in many ways the challenges are the same. So but I think our particular perspective, or my particular lens that I'm offering here from Plan, is that we are, since we're looking holistically at young people, concerned about some of these other social and economic challenges, and particular to issues of inequality and the layered kind of exclusions that we're seeing being exacerbated by COVID, on top of that list of many other things that multiple countries are experiencing multiple crises at a time. So COVID is just as well affecting people in the US as it is refugees in countries where they may already be dealing with drought and other conflict. There's just a wide range of challenges that we're seeing across these countries. And for adolescent girls, I think in particular, there are just particular patterns that we're seeing because of the disparities in access to services and the social status of adolescent girls. Some of their needs are often sort of pushed aside, and the health systems, trying to respond to COVID can sometimes deprioritize things like sexual and reproductive health, which can really lead to deadly effects for young pregnant women, for example, young adolescents who may be pregnant or may be more likely to experience violence or teen pregnancy. We've seen this from past crises, and the patterns that we're starting to see now are really similar to what we've seen with Ebola in West Africa. This is a report pictured here that has been recently published, and I think the concern then is that COVID, for example, with all of the information sort of still being, there's a lot of knowledge gaps that we're seeing, and communicating that knowledge to countries that have different contexts and circumstances, we don't really know. There are things that that remain to be seen. Will young girls that in countries that are affected by COVID have challenges in accessing other life-saving services? Will the economies as a potential second order kind of effect of COVID lead to an increase in child early and forced marriage, which very much has an economic kind of driver to it? Women and young and girls are often, in many countries, have an increased risk exposure due to gendered roles as caregivers, or in some cases they're disproportionately represented in even formal caring roles such as nurses and frontline healthcare workers. And then on top of that, there's that comes on top of kind of development goals and outcomes where girls are already behind. They're already struggling to transition into secondary school, and there are already certain health services are not necessarily prioritized during crises. So then on top of that, I think the point also that's been raised by other panelists about the access to digital, we're all sort of, I think there's a lot of buzz about digital technologies and virtual solutions, and in many ways we must do that. And I think the nonprofit sector has perhaps been quite behind in this more than other sectors. And so it's necessary, but at the same time, for organizations like Plan, who are working specifically with groups who are more marginalized, and there is a gender imbalance in access to mobile phones and digital literacy, and then even just more globally, access to 4G and internet and even cell phone coverage is not universal. So this is affecting many of the places where we're working. We were able to do sort of a rapid assessment in Zimbabwe and Senegal. This is just a brief sort of summary of some of the specific challenges that girls themselves are facing. So as part of our goal and how we see problems being best solved is to work in partnership with communities. And I think that was just mentioned. I think Michael just mentioned that, or was it Maurizio? But the importance of human-centered design is central to our approach in Zimbabwe, for example. And we have found that it is possible to still seek input and understand what the priorities are of girls and people that are affected by this crisis. And these are just some of the things that they mentioned. And some of them have potential. They're challenges that are I think can be addressed through innovation. But I think the thing that I just want to highlight is the fact that these girls being a good example where we were able to reach some of them by phone, just regular phone, but they are also they're expected to call their teachers and get their assignments, but they don't really have textbooks. And so there's all these cool digital learning apps, but this isn't really a solution for these girls in particular. So I really appreciate that point about making sure innovation is accessible, affordable, and appropriate. And I would also just emphasize that we also need to be sure that we're looking at equity. We want to be sure that we're reaching people, and we're also not we're not doing harm in sort of delivering these solutions to some people and leaving others further behind. So I think just sort of this is a kind of a cartoon depiction of the operating environment to just kind of hit home, to kind of emphasize some of the challenges and the fact that we're, working in a federated structure where we have many different offices, many different countries and contexts with a really dynamic circumstance. And so keeping up to date and making sure that we are providing solutions and, working to find solutions that are really relevant. So working in partnership with different communities, but even within countries, there are differences, within countries and even within communities. And then when you start to look at subpopulations, like adolescent girls and different, and all their diversity, there are different languages, there are different literacy capacities, there's different, physical disabilities or their visual disabilities. So these are really, I think, critical questions to ask as we're looking for innovation. I think these questions need to be at the core. And keeping our staff safe, of course, is also a challenge and important to us, and ensuring that people have access to information, up-to-date information. So that need to really gather data and predict, as it was mentioned in the previous panelists, to sort of use, whether it's data analytics to better sort of predict leading and looking at lagging indicators, so that we're able to get a real sense of the environment in a timely manner, so that we can operate adaptively and iteratively. So I mean, this is sort of our, our big question that's keeping us up at night, is how do we, in this complicated environment with all of these challenges, how do we deliver a response that, that's really centered on youth and that's driven by them, so that they can survive and thrive in the future. We're expecting second order, challenges, perhaps economic, perhaps they could be health or social or education challenges. Some are predicting maybe, young people will leave and not go back to school. That's a very real possibility for some young girls who may have been in school. And then we have certain minimum standards, like do no harm is the first one. So safeguarding and protection, but I would add to that, ensuring that we're not increasing, inequities or inequalities in the service that we're providing. Staff safety is obviously a key concern, meeting the immediate needs, but also understanding how this relates to longer term issues. And a real important, a real key challenge, I think, as well, is and I think it's part of the solution, is wanting to support local coping strategies and solutions. What are young people, what are communities already doing? There was a story, I think, recently about, a female cassava-owned farmer who used cassava to make hand sanitizer. I mean, there's many different stories like this. There's a lot of innovation that's happening on the ground that young people are doing, doing what they need to do. They're responding creatively and resiliently. So I think the key to solving these challenges is really looking for that and supporting that, and trying to provide, sort of invest in a way that supports that. so I think just you know, and sort of coming to a close here with my remarks, the key, I think, is to really think about not just the response, but, you know, an organization that works both in emergencies and development settings, where we're seeing this as a long-term process. We need to ensure that people are, and particularly young people, are able to meet their immediate needs. But how do we, you know, build back better? How do we take this opportunity and kind of look for ways to take advantage of the disruption? And you know, people get stuck in their ways of how to do things, and so really the disruptive environment can be a real opportunity. And how do we, you know, vastly enhance the scale, impact, value for money that from investments in the philanthropic sector? And how do we meaningfully engage youth and communities virtually? That's a huge challenge. How to speed up equity and equality using new approaches, and how to learn, you know, sort of more adaptive, how to be more agile, and learn quickly and then adapt, and you know, as will be needed in this changing environment with unknown impacts. So yeah, just in closing, I think that's sort of my perspective, and thanks for the chance to participate.
The quote really sums it, Molly. Thank you so much for your presentation. I know we have reached our time, but if the panelists are open to quick 5 to 10 more minutes, we have two of our Shah Lab affiliated faculty online who might want to, who have a question they want to address directly, if that's okay. Thank you. Okay, so we have, by the way, just want to quickly also highlight that we received more than 60 questions online through our pre-event survey. And we had curated a few, but I don't think we have enough time to go over them. So we'll begin with the questions that our affiliated faculty have. Dr. Yi, if you are online, please do state your full name and affiliation, and also the panelist you're posing the question to.
Thank you. My name is Yue Yi. I'm a professor in industrial engineering. And thank you for all the speakers. That's a really insightful information. And this question is for both Michael and Lindsay. My research group has been developing solutions to support supply chain management in low resource setting, including emergency response and medical supply chain in LMICs. For the medical supply chain project, we actually focus on the last mile at a clinical level by sensing the demand for using a real-time patient record to predict the needs of laboratory supplies and medications. And they are both funded by the Shah Lab and other organization foundations. So as we respond to the COVID-19 and prepare for future pandemics, where do you experience the gaps in the health supply chains and digital capacity in the LMIC and or in US that you think the research community can take action to contribute now? Thank you.
Michael, since Lindsay is not here, do you want to take a stab at this question?
I'll take a stab at it. I'm not a supply chains person per se, but in the work that I've done more broadly, but also on healthcare in middle income countries. My particular focus is on less on sort of the digital side or anything, just like really basic things like getting people to show up for work, right? And if you can get people to show up for work, then maybe there'd be these huge big gains. And so I try not to get too sort of absorbed into a world of the high tech things. I just want to get things walking before they can run. That said, I'm very conscious that there are obvious big problems in supply chain issue management, but there are also incredible ways in which groups are able to address those. I often ask my students, sort of, why is it that you can get Coca-Cola pretty much anywhere in the world, whereas you can't get basic medicines anywhere in the world. And the usual answer would be just because they've built out these amazing supply chains that are able to do that. And so given the sort of vantage point from which I engage with these questions, my instinct is to be really good at documenting your own experience, but not see that you've reached the apex and cracked the code and found the solution. I mean, I think a part of our job as external experts is largely to support people that are already have a mandate and have a responsibility to respond to these issues. And when we decide what their problems are, then I think we just complicate their lives. So if a prior analysis had showed, yes, indeed, there is just a serious problem with supply chain management issues, and the kind of approach that you happen to have and your teams had been working on and had a good solution to it, then yes, then you offer that up. But then you kind of expect that there's going to be some idiosyncrasies. They won't exactly look like the problems that other people that you've worked with have worked on. And so you need to try and be really sensitive to the idiosyncrasies of that particular challenge, and then document what those were and keep that process going, because as Lindsay's presentation remarked, her life since February when she joined has been one constant sense of iteration and learning on the job. And that's the mark of a well-functioning organization, is when it can solve the problems that it confronts. And so to the extent that supply chain management issues are indeed a binding constraint on other good things happening in the world of healthcare, and you happen to have a fix for that, so to speak, then as long as you're responding to the people whose job it is to decide what priorities they actually face, and you can then do your job as an outsider by both providing that response, but then sharing the idiosyncratic way in which that particular solution was enacted, and put it back into this loop of learning. That's how organizations learn. That's how they get better, and that's how these systems in general learn. So that's the big challenge, is helping to build the organizational capability to do that, and routinizing problem solving as the way in which we engage these things.
Thank you so much. Dr. Linus, do you want to go next?
Yes, thank you. So I'm an assistant professor in biomedical engineering, working on point-of-care diagnostics here at Purdue. And my lab's, well, first, I guess I'd like to address the question to Mauricio and Molly. My lab has been developing low-cost point-of-care diagnostics for nucleic acid detection of HIV and protein detection of cervical cancer. And they've been funded by the Shah Lab in the past, which we very much appreciate. And like many technologists and diagnostics developers, we've transitioned these platforms towards COVID-19 detection. And we have clinical partners in various countries, and particularly LMICs, but we are not manufacturers, and they are not manufacturers. And so I'm wondering, is there a gap in local manufacturing? I do have some students in Ghana that are working on this. A former student of mine runs a company there. But is there a gap in local manufacturing and testing in LMICs, and how do we overcome just a north-south attempt at providing technologies? And maybe there's leapfrogging that's happening and I don't know about. Can you speak to that at all?
Molly, do you want to go first quickly? Yeah.
Oh, sure. Yeah, no, I mean, my perspective would be that there is. I mean, I think I know with the PPE, for example, there are challenges and there's an interest in, ensuring quality. So we aren't involved in this directly, although we are involved in PPE, supporting businesses to do PPE. But I would say that there is a gap, and yeah.
Okay. Mauricio, do you want to?
Sure. Good to see you, Jackie, and great work, by the way. I'm familiar with your work. So the answer is yes. The gap is huge. And if you want to buy into the scenario that I painted, where the need for these kind of things, especially on the testing side, is going to be not an emergency use one, but a protracted use one that may just pervade the healthcare system. Then the corollaries or the implications of that is that the success is not just the development of the technology, not to trivialize the work that needs to go on the R&D side, but it really is one of logistics and execution from the business perspective and from the manufacturing and from the scale up, et cetera. You may have caught some of the press around the Gates Foundation and Bill's set of issues around new vaccines, where the issue, of course, getting to a vaccine is important and making sure that it's safe. But beyond that, logistics issues like making sure there is enough glass vials made to actually address all the people that will need the vaccine, those are daunting for first world logistics, let alone developing world logistics. One of the things I predict is going to happen around this sort of crisis around medical supplies, the kind of scenarios and issues that Dr. Lindsay talked about before, is that, you know, part of achieving success with these products is going to be to really address the supply chain and logistics aspects of it. And I think localized manufacturing might be one of the enduring changes, where we're going from global supply chains with manufacturing in certain hubs such as China and a lot of east-west type of trading to much more localized capacity. And I think therein, by the way, lies an opportunity for LMIC, where all of a sudden, instead of just being net importers of technologies and supply chains, they might actually become contributors to their own self-sufficiency. And, you know, but it does require, the key question is who's going to pay for it? And it does require, beyond the foundations and the nonprofit sector that is going to be helping some of these trends, it's going to require really business sector vision to see those opportunities, to partners with the innovators like yourselves, and ultimately to make that happen. From a purely speaking innovation perspective, and I think you know that well in your product line or development, looking at the form factors, looking at the usability, starting to design for manufacturing so that it is feasible to have things done with the sort of capacity requirements that may be needed, and the local manufacturing environments that doesn't require global supply chains or has bottlenecks in certain things like reagents that can only be gotten from some people. Even from a tech transfer perspective, from the university perspective, looking at novel global access, licensing, and use of IP. Those are all sort of trends that are encapsulated in this. And yeah, I know it puts you as a scientist and as an engineer into the business of being a business architect, but to some extent, that's what we need to do. And I think all of us involved on the research side need to really act as an impetus to the business sector to help them understand the opportunities so that these things can see the day of light in the places that are needed.
Thank you very much. And thank you everyone for such wonderful, informative, and thought-provoking discussion. I know you're all very busy with critical work, so we really appreciate your time in engaging in this discussion. I know I'm stretching the time here, but before we end the session, I was wondering if there is one sort of closing thought or a takeaway that you want to share with our audience. We can start with Michael and then Maurizio and Molly, if you have one closing thought for us.
Yeah, I just think maybe it's a cliche, but if we have if global problems are ones by definition that affect all of us, I think that there can be some global solutions in all of this as well, and that we have to rethink multilateralism as part of this whole process as well. Every problem, every big problem we confront for eternity is now going to be very quickly a global problem. And just as our forebears showed enormous imagination and courage to set up what we now have and still have as our multilateral institutions, I think there's a big need to think about how we design 21st century multilateralism to deal with these big challenges. So as much as we have really brave and creative people doing things at the front lines and in supply chains and all those crucial parts of the ecosystem, as it were, ultimately all this, the potential gains from this can be really only harnessed if humans confront the basic question they've always confronted, which is how do we get along with each other? How can we actually recognize our shared humanity in all of this? And from basic stuff like not just hoarding masks and vaccines and all of this, but actually figure out how to work together to deal with these challenges and the zillion others that are going to keep coming along. So I guess my plea is to sort of work locally and think globally and all those other cliche type things as well. But now they're not cliches; they're real, and they need to be addressed and taken seriously for the problems they are. So, and secondly, that everyone should just keep doing what they're doing. You know, everyone's good, especially in this type of audience, has got a very particular form of expertise. It might not seem that big a deal, maybe, but somewhere, somehow, it can be offered up. Somewhere, somehow, it can contribute to being part of someone else's solution. And so, rather, we don't have to be all things to all people. We just have to do what we're good at. We've all been blessed with particular talents. We have abilities. Then, when those get added and multiplied by with everyone else's seemingly obscure talent, it all works. And that's the mystery of human existence. And I hope that we find or discover again in this challenge that we have a shared humanity and that we're at our best and when we work together to solve these things, even as these crises by definition have the potential to expose the worst that we are as well. Thanks.
Maurizio, any last thought for us?
Yeah, I wanted to come back to sort of a call to action to the community of innovators. The innovation that is going to make a difference is not a point solution. It requires interdisciplinarity. And in that interdisciplinarity, you have to layer in all the things we talked about, multiple speakers have talked about, that loosely speaking relates to human-centered design. But more importantly, you need to look at what is the interaction between social, the community, the how the product is going to be used, and ultimately how it's going to generate its impact. So it's no longer sufficient to talk about a target product profile limited on some specific performance. To beat on Jackie's work on testing, it's no longer sufficient to have an optimal sensitivity and specificity. You have to look at the whole interdisciplinary utilization of that product and intended use. And, you know, I was reminded by a social scientist the other day that interdisciplinarity is really the integration of disciplines. It's not just using multiple disciplines to achieve an objective. And so integrating these social dynamic issues, these economic issues, these technical issues, integrating disciplines within the technical issues, including, you know, the data science, all those things is really where the innovation of tomorrow that will have a lasting impact is coming from. So I urge you guys to be collaborative and collaborative across those disciplines.
Thank you, Maurizio. Such a critical point. Molly?
Thanks. Yeah, I would certainly agree with what Michael and Maurizio said. I would perhaps also maybe just reinforce some of those points and call for just a reminder that what we need is innovation and not inventions. So inherently, you know, innovations are something that are used. So otherwise it's just an invention. And the key to that, I think, are some of these points like systems thinking and interdisciplinarity, but also very necessarily including the context experts. So people who are affected by the challenges that we're all discussing have a very particular context, and we need that expertise in addition to a variety of other expertise to solve these challenges. I think we will. I'm very optimistic that we will.
Thank you so much, Molly, and thank you everyone for again taking the time out to talk to us and to engage in this discussion. On behalf of Shah Lab and College of Engineering, I really want to thank you again for this. And stay safe and take care. Thank you very
everybody.
much. Appreciate it.
Thank you.
Bye.